Salam alaikum. It's a new series, usmle inner circle series, likely to discuss about the usmle inner circles. Hope you've enjoyed. This is a very great PDF where you can get all the step to concept in a concise manner, and you will get you will be benefited from here. Okay, now now I would like to discuss about first topic regarding infectious disease, that is catheter related infection. Catheter related infection. How will prevent prevention of central line associated bloodstream infection? How prevent central line associated bloodstream infection? First, hand hygiene. So using gloves can help you. Full barrier precaution like masks, sterile gloves, gowns, wrappings, and the chlorhexidine solution and procedure performed by the experienced hand, that is one of the important. So during catheter insertion, these are the techniques you should follow. In catheter types and site, if you are using use of peripherally inserted central catheter and tunnel catheter. For central venous catheter, use of subclavian and internal jugular vein side over femoral vein. This is very high yield. That use subclavian and internal jugular vein. Sometimes for better positioning, to look at the correct positioning, we use ultrasonic guided techniques while doing especially the internal jugular venous side. That will give you a perfect uh, placement and decrease chance of infection, as well as these type of catheterization like subclavian and internal jugular vein, sometimes pneumothorax may happen, so that should be in the consideration. After doing these catheterization, you should do a chest x-ray to look for pneumothorax. Catheter duration, limit duration less than 6 days for central venous catheter. Limit duration less than 6 days for central. Prompt removal of catheter when no longer needed. Prompt removal of the catheter when no longer needed. Avoid routine placement of central venous catheter. Okay. CONS, coagulase negative staph is the most common cause of catheter related bloodstream infection. So coagulase negative staph is the most common cause of catheter related bloodstream infection. Typically occurs more than 48 hours after the catheter insertion. Patient with suspected catheter-related bloodstream infection should have two sets of blood culture, one set from the peripheral side, one set from the catheter, one set from the peripheral side, one set from the catheter. These helps to differentiate contamination. One of the four culture is positive from true infection, like the differentiate contamination is one out of four culture is positive, and if 4 out of 4 culture is positive, that means it is actual infection, it is true infection. And the CONS, coagulase negative staph, that means staph epidermidis and saprophytic as common cause of catheter related bloodstream infection. Catheter related bloodstream infection occur approximately once per year in patients with tunneled hemodialysis catheter. So catheter-related bloodstream infection occur approximately once a year in patients with tunneled hemodialysis catheter. Most cases with Systemic signs of infection, fever, malaise, chills without localizing symptoms. The catheter site frequently appears normal. Initial therapy uses antibiotics, fluid resuscitation, and removal of the catheter. That's it. So this is all about catheter-related infection. Now I would like to discuss about the infection control. These are the very mm, abnormal topic. I'm talking it abnormal as because these questions are very hard to deal. Okay, airborne, contact, droplet, and standard. So A, C, D, S. Airborne, airborne. It may be bacterial like TB. It may be viral like chickenpox, shingles, COVID-19, measles. How do keep key requirement in this aspect? We know that COVID-19 we use N95 and negative pressure room for infection control. In contract, in contact, multi-drug resistance organism like MRSA, VRE, ESBL, MRSA, VRE, ESBL producing bacterial like C. diff, E. coli, O15787, and viruses are again the chickenpox, varicella zoster, these and that, and contacts like gloves and gowns, and single use of equipment stethoscope, single use of equipment stethoscope, and the droplet is Neisseria meningitis, Haemophilus influenzae, Mycoplasma pneumoniae, and virus is influenza and adenovirus. Mask within 1 to 2 meter and 3 to 6 feet of the patient. And the standard one followed for all the patient even no infection is apparent, like hand hygiene, gloves, gown, gloves, mix when appropriate. Okay, next. Now, gonococcal arthritis and non-gonococcal. Gonococcal arthritis by Neisseria gonorrhoeae, non-gonococcal chlamydia, ureaplasma, mycoplasma, chlamydia, ureaplasma, mycoplasma, trichomonas, and the drug in non-gonococcal conjunctive urethritis is azithromycin, and gonococcal is ceftriaxone. Urethral stain shows intercellular gram-negative diplococci, and non-gonococcal urethritis. There is aseptic and leukocytosis, and watery scant. Patients with non-gonococcal urethritis uh, frequently have a continued symptoms after azithromycin therapy. Azithromycin therapy due to reinfection resistant infection with an organism Mycoplasma genitalium are not susceptible to azithromycin. Patients should receive repeat urethral gram stain and nucleic acid amplification testing of the urine for common urethritis organism to identify the best next management. All sexually active women less than 25 are recommended for annual screening for chlamydia trachomatis and Neisseria gonorrhoeae, including with low risk sexual behavior, monogamous condom use because these have high prevalence, often asymptomatic. Azithromycin is a first-line therapy for non-gonococcal conjunctivitis. Alternative, their treatment failure often necessitates an alternative antibiotic to treat non-chlamydial organism. These are moxifloxacin and metronidazole. Mm, like mycoplasma, you can give moxi, trichomonas vaginalis, you can give metro. That is all about. Chlamydia and gonorrhea, age less than 25, high risk sexual behavior comes with cervicitis, uveitis, urethritis. This is very high yield fits, Hugh Curtis syndrome, perihepatitis associated with PID. We can do NAT, nucleic acid amplification testing, and if empiric ceftriaxone plus azithromycin, if confirmed chlamydia confirmed chlamydia, you can give doxy. In pregnancy you can give azithro, and confirmed gonorrhea ceftriaxone is the drug of choice, and the chlamydia gonorrhea side uh, complication is pipe. PIPE, pharyngitis, infertility, PID, ectopic pregnancy, pharyngitis, infertility, PID, ectopic pregnancy. These are the things can happen. Okay, STD screening all patient for STD, chlamydia, gonorrhea, syphilis, HIV, chlamydia, gonorrhea, syphilis, and HIV, chlamydia, gonorrhea by NAT test, syphilis, and RPR and VDRL should be done. And HIV fourth generation antigen or antibody. Additional testing for certain population women, only trichomonas vaginally, herpes virus, herpes serology only when history of characteristic lesion, lesion. For patients with active sexually transmitted infection who have low risk, HPV screening is reserved for women or men who have sex with men. Anal routine screening heterosexual men is not common. Although chlamydia trachomatis should inform current and recent sexual partner, so they be tested and treated. Otherwise, reinfection is common. All patients with chlamydia trachomatis should inform current and recent sexual partner they get, so they can get tested or treated. Otherwise, reinfection is common. For patients who test positive should receive antibiotic immediately and refrain from sexual intercourse until treatment is complete. All sexual partner of the preceding 2 months on preceding also should be tested and treated. Treat both partner for trichomonas if asymptomatic and screen for STD. Treat both partner for trichomonas if as even if asymptomatic. Even if asymptomatic, also screen for STD for these patients. For STD, the four tests are gonorrhea, chlamydia, gonorrhea, syphilis, and HIV. Chlamydia, gonorrhea, syphilis, and HIV. Cat bite, Pastorella multisida, and anaerobic bacteria. Their management is copious irrigation, cleaning, prophylaxis, prophylactic amoxicillin or clavulanic acid, tetanus booster as needed. Avoid closure. What are the common pathogens? Pastorella multisida cat, capnocytophagia for dog, and also consider rabbits. And dog bite, irrigation debridement allows spontaneous closure, augmentin or amoxicillin clavulanic acid. Tetanus, if indicated, if last vaccine is more than 5 years. And the two topics. Now the two topics: lymphadenitis. Lymphadenitis, inflammation of the lymph node. It may be tender, enlarged, warm node, enlarged, warm node, tender, enlarged, warm node. If the lymph node is soft, mobile, less than 2 centimeters, soft, mobile, less than 2 centimeters, and location, it is localized. There is no systemic symptom. It is localized. Exception is supraclavicular nodes, and example like systemic features like fever, weight loss is absent. It is reassuring and worrisome thing. worry if it is firm or hard, if it is immobile, and if it is more than 2 centimeter. Location is generalized and present. What is the next step in the management of asymptomatic adolescent? That presence with soft mobile non-tender cervical lymph node, soft mobile non-tender cervical lymph uh, observation, that is observation. Further workup is needed indicated if lymphadenopathy persists or if lymph node enlarges. Palpable supraclavicular lymph node should be considered pathologic. Palpable supraclavicular lymph node should be considered pathologic until proven otherwise because they are associated with GIT, genitourinary pulmonary malignancy, GIT, urinary pulmonary malignancy. This is very high yield, very, very, very. Cervical lymphadenitis, very, very, very high yield. If it is unilateral cervical lymphadenitis, first is unilateral is bacterial, bilateral is viral. Unilateral is bacterial, bilateral is viral. Unilateral bacterial Staph aureus strep pathogens. It may be acute, most common, and separation is common. Unilateral anaerobic bacterial like Prevotella history of periodontal disease or dental caries, Francisella, Mycobacterium avium, chronic non-tender violaceous, and Bartonella hansley, chronic papule at the site of cat scratch or bite, papule at the site of cat scratch or bite, papule at the site of cat scratch and bite. Every empiric antibiotic for acute unilateral lymphadenitis is typically clindamycin or amoxicillin and has high activity against MRSA or streptococcus and has activity against MRSA and has activity against amoxicillin has activity against MRSA and streptococcus. So acute unilateral lymphadenitis typically treated with clindamycin. Most common is staph or aureus or strep pathogens. Other prevotella with periodontal disease, Francisella, rabbit, Mycobacterium avium, non-tender violaceous, Bartonella hansley, papilla at the side of the cat scratch. Hmm, that is it. Okay, now characteristics of ulcerative sexually transmitted disease. Start with this Shrankoid. Shrankoid caused by the Haemophilus do you cry? Do you cry? Initial lesion is painful. Uh, in here you can say the primary lesion there is multiple deep ulcer. A base may be gray to yellow exuded. An organism often clumped in long parallel strand. School of fish. Shrankoid. Do you cry? Painful ulcer. In genital ulcer herpes, there is painful ulcer, painful low node. It is multiple small grouped ulcer caused by the HSV1 and 2 shallow erythematous base. And in here, you will get internuclear inclusion like Cowdrey inclusion type 1. And initial lesion is painful. Granuloma inguinale, donovenosis. In here, what you will get that extensive and proliferative ulcerative lesion without lymphadenopathy. Donovenosis does not show lymphadenopathy. Extensive and progressive ulcerative lesion without lymphadenopathy, and deeply staining gram-negative intracytoplasmic cysts like Donovan body. In here, initial lesion is not painful. Syphilis is painless ulcer, painless node caused by Trypanosoma pallidum, and the granule and lymphogranuloma venerum. Lymphogranuloma venereum caused by the Chlamydia trachomatis. Lymphogranuloma venereum caused by the Chlamydia trachomatis. In here there is shallow small ulcer. There is shallow small ulcer. There is shallow small ulcer. A large painful pulsing inguinal lymph node like buboes. Large painful pulsing inguinal lymph node like intracytoplasmic chlamydial inclusion body in the epithelial cells or leukocyte. Lymphogranuloma venereum. Hemophilus do query bacterial culture and HSP PCR testing. More testing specific for zinc. More testing specific for zinc. Okay, now if we are like to talk about the prolonged 2 weeks traveler diarrhea, prolonged 2 weeks, prolonged more than 2 weeks of traveler diarrhea. Think about entomybastolytica. Think about entomybastolytica, giardia, cryptosporidium, and cystoisospora and cyclospora. Entomybastolytica, giardia, cryptosporidium, cystoisospora or cyclospora. Uh, Entamoeba histolytica, giardia, cryptosporidium, or cystoisospora and cyclospora. Entamoeba histolytica, it may be bloody or mucoid diarrhea, extraintestinal disease, liver abscess, extraintestinal disease, liver abscess. Giardia is watery, oily, foul-smelling stool, watery, oily, foul-smelling stool. There may be bloating, fat, malabsorption, weight loss, and cryptosporidium or cystoisospora watery diarrhea in an immunocompromised, immunosuppressed patient, and cyclospora watery diarrhea with or without blood. Cyclospora vaccine and waning symptoms. When infectious disease is prolonged more than 2 weeks, when infectious disease is prolonged more than 2 weeks, the causative pathogen is typically parasitic rather than bacterial or viral. So prolonged 2 weeks of traveler diarrhea in amoeba. It can cause bloody diarrhea, giardia, fatty diarrhea, cryptosporidium, parvum, or cystoisospora, cyclospora. All of them cause watery diarrhea actually. Okay, now infectious bloody diarrhea. Infectious bloody diarrhea. In infectious bloody diarrhea, there may be Shiga toxin producing E. coli, Shigella, Campylobacter, and Salmonella. So Shiga toxin producing E. coli, Shigella, Campylobacter, and the Salmonella. Shiga toxin producing E. coli history, ingestion of the undercooked beef and absence of high fever. Ingestion of undercooked beef and absence of high fever, and it can cause Haas hemolytic uremic syndrome. It can cause Haas hemolytic uremic syndrome. And Shigella actually cause bloody diarrhea. Bloody diarrhea, ingestion of contaminated food or water. Antibiotic if severe. Campylobacter causing GBS. Ingestion of raw or undercooked meat. Ingestion of raw or undercooked meat. Supportive care. Antibiotic if severe. And Salmonella. Ingestion of undercooked chicken. Ingestion of undercooked chicken. Ingestion of undercooked chicken. Supportive care. Antibiotic if severe. Bacteremia. For example, E. coli 157H7, Guillain-Barré hemolytic uremic syndrome. In contrast, E. coli 157 diarrhea and shigellosis antibiotic do not increase the risk of Haas. Increase the risk of Haas. In contrast to E. coli 157 diarrhea in shigellosis and in shigellosis antibiotic do not increase the risk of Haas. Shigella cause high fever, cramping, stools that are initially watery before mucus or blood, tenesmus, seizure, rectal bullous due to severe rectal inflammation, potentially involves rectosigmoid junction, left lower quadrant. Lack of fever is typical on infection with Shiga toxin induce Escherichia coli and EHEC. Although a minority of the patients with staph gastroenteritis have low-grade fever, presence of temperature, an alternative diagnosis ETEC, watery diarrhea with few days giardia, foul-smelling diarrhea after a week. Okay, if we look at this chart, very high health. If somebody comes, if somebody comes with high risk features, if somebody comes with high risk feature, if somebody has a like a gastroenteritis, high risk feature, bloody stool or high fever, severe disease, hospitalized, elderly immunosuppressed, and diarrhea more than 7 days. Yes, go for FMS. That means fecal leukocyte, maternal PCR, and stool culture. If fetal leukocyte is positive and is stool culture, you get bloody stool, then it is inflammatory diarrhea. And then the PCR testing. Then we should look for PCR testing. In PCR, if there is stack, staph, if there is stack, that means Shiga toxin producing E. coli. If it is stack via PCR, avoid antibiotic. If non-stack, like if stack via PCR, avoid antibiotic. If non-stack, consider antibiotic. If Shiga toxin producing E. coli, avoid antibiotic due to Huss risk, intravenous volume expansion. Non-stack, consider antibiotics, severe disease, immunosuppressed patient with low infectious disease, those pathogens with low infectious dose, Shigella, and if it is non-inflammatory diarrhea. But in stool culture, there is fecal leukocyte, maternal PCR, and stool culture. Uh, all is positive, but it is non-inflammatory. If non-inflammatory diarrhea, then go for this antibiotic. if if somebody has no high risk feature, no high risk feature, supportive care, fluid replacement only, supportive care, fluid replacement only. Okay, for inflammatory and non-inflammatory diarrhea. Inflammatory diarrhea often with bloody mucoid, fetal RBC and leukocyte, usually watery, no RBC or fecal leukocytes. Pathogens are non-inflammatory like viruses and bacteria like Staph aureus, Bacillus cereus, Clostridium perfringens, ETAG, Vibrio cholerae, Listeria, parasites like Giardia, Cryptosporidium, Cyclospora, and inflammatory like non-typhoidal Salmonella, Campylobacter, Shigella, Staph, Yersinia, Vibrio. Okay, look at the bacterial gastroenteritis. In bacterial gastroenteritis, this too is very high yield. Noro most common in all ages. Noro rota, no ro ro rota, noro rota, noro rota, noro all age. Rota is unvaccinated age less than 2. Naro rota, feco oral. It is feco oral. It can cause emesis, watery bloody diarrhea. It can cause abdominal pain, fever. Diagnosis clinical fluid repletion, oral or oral for mild rehydration, infectious for intravenous for severe dehydration, and regular diet limit fats, simple sugars as tolerated. Consider bacterial parasitic pathogens so following grossly bloody stool, persistent fever exposure, this and that, and what about? Okay, diarrhea and vomiting. If somebody comes with foodborne disease, if somebody comes with foodborne disease, first ask, is it vomiting predominant? Is it watery diarrhea predominant? Is it inflammatory diarrhea dominant? Is it non-gastrointestinal symptoms? If it is vomiting predominant, then think about Staph aureus. Think about Bacillus cereus. Think about Noro. So if it is vomiting predominant, Staph aureus, Bacillus cereus, Noro. If it is water and diarrhea predominant, think about Clostridium perfringens, ATAC, enteric virus, Cryptosporidium cyclospora, and intestinal tapeworm. And if it is inflammatory, diarrhea predominant, inflammatory diarrhea, predominant. Think about Salmonella, Shigella, Shigatoxin producing E. coli, Salmonella, Shigella, Enterobacter, Vibrio. Years it is non-gastrointestinal symptom, botulism, Ciguatera scromboid food poisoning, Vibrio, non-gastrointestinal symptoms, Vibrio hepatitis A, brucellosis. Okay, major pathogenic mechanisms of foodborne enterotoxin ingestion, Staph aureus bacillus quick onset, 1 to 6 hours of vomiting predominant in enterotoxin made in the intestine, enterotoxin, Shigatoxin, producing E. coli and Clostridium perfringens, Vibrio, delayed onset more than 1 day, watery or bloody diarrhea, and bacterial epithelial invasion. It also causes watery diarrhea, fever, and epithelial invasion, Campylobacter jejuni, non-typhoidal salmonella, and Listeria monocytogenes. And Listeria monocytogenes. Last topic for this continuation of these infections regarding USML inner circle, then is for now is toxic shock syndrome, fever more than 102, hypertension, diffuse macular erythroderma, fever, hypertension, diffuse macular erythroderma. There may be skin induration including palms and sole, 1 to 2 weeks after the illness onset, and multi-system involvement, 3 or more than 3 symptoms. GI symptom, macular, mucous membrane hyperemia, renal, BUN, serum creatinine, hematologic, liver abnormality, STLT, total bilirubin, and central nervous system altered mentation without fecal neurologic sign. Since there is no test for toxic shock syndrome, Staph aureus, blood culture are often negative. Blood culture are often negative and high clinical suspicion, high fever, hypertension, diffuse maculopapular rash covering palms and soles similar to sunburn, and multi-system involvement, thrombocytopenia, myalgia, vomiting, altered mental status. That is all about toxic shock syndrome. Now, burns. What are the most common organism for burns? MRSA, Pseudomonas, MRSA, vancomycin, Pseudomonas cefepime. Treat empirically if infection or sepsis occur immediately after gram-positive organism Staph aureus and in 5 days. Gram-negative Pseudomonas, 5 days. Gram-positive and Pseudomonas. Gram-positive or Pseudomonas. Gram-negative Pseudomonas. Gram-positive organism immediately after gram-positive organism is Staph aureus, and gram-negative is Pseudomonas.